Okay, I guess we'll go ahead and get started. Happy New Year, everyone. We'll start off by talking about assessment of the right ventricle and right-sided heart valves approach by CMR. So I'm going to start off with just a little bit about background, talk a little bit about the pathophysiology of RV dysfunction, and then talk about how CMR approaches assessment of the RV. And then we'll wrap up with talking a little bit about the tricuspid valve. So a couple of things to keep in mind, although we tend to think of the LV and the RV similar, they're very different structures, in fact. Although the RV pumps the same stroke volume as the LV, it tends to be a little bit larger than the LV, typically about 10 to 15% larger. And as a result, if it's maintaining the same stroke volume with a larger chamber size, it's going to have a lower ejection fraction. So in fact, a normal RV ejection fraction is a little bit lower than the LV ejection fraction. The other important thing to keep in mind is that the RV is pumping against a lower pressure system. And in fact, it only has to do about 25% of the stroke work as the left ventricle does in normal settings. Now, obviously, in the setting of patients who have pulmonary hypertension, the workload on the right ventricle is increased, and that's one of the things that leads to RV decompensation. But since it's pumping against a much lower pressure, lower resistance system, the RV is a much thinner, more compliant chamber. So normal RV wall thickness shown here is about 3 to 5 millimeters, whereas normal LV wall thickness is around 10 to 12 millimeters. So again, a thinner wall, much more compliant, has to pump against much lower pressure and resistance. The other thing is that the LV and the RV are interlinked, and they in fact share the septum. The interventricular septum is really shared between the LV and the RV. And then there's also these mutually encircling epicardial fibers, as you can see in this example right here, where the fibers actually cross over the LV and the RV. And then obviously the attachment of the RV free wall to the septum is where the two chambers meet. So you have the anterior RV insertion site, which is shown here, and then the inferior RV insertion site, which is shown down here. In addition to that, the LV and the RV also share a pericardial space, so that's an important thing to keep in mind as well. And I think it's important to recognize that the interventricular septum and the free wall of the RV contribute almost equally to RV function. So when we think about RV function, really want to think about it both from the effect that the interventricular septum has, as well as the effect that the RV free wall has. Now, another important distinction is that longitudinal shortening is a much greater contributor to RV stroke volume than short axis or circumferential shortening. And so as a result, when you're assessing the RV, it's actually better to look at it off of long axis views than it is off of short axis views for two reasons. One, again, since the longitudinal component is what leads to a greater effect on the RV stroke volume. In addition to that, there's another thing you have to keep in mind, is that when you're looking at short axis views of the right ventricle, notice that the RV is kind of a funnel-shaped structure. And what happens during systole is that the entire basal plane will descend down towards the apex. And so any given short axis orientation or location that you have actually is going to be imaging a little bit higher up during systole. So what's happening is as those as that myocardial fibers descend down, it's actually wider at the base. So you get this false appearance, especially near the mid and basal slices, that the RV on the short axis view may not be contracting as well as it is. And again, that's why if you really want to assess the RV, it's important to look at the short axis views. You can see that here. If I had a particular short axis slice right here, and if I just looked at it on the short axis views to say what's the distance between the septum and the RV free wall, you'll notice that even though this is a normal right ventricle, it can look like the distance is actually not shrinking. In fact, may even be increasing during systole. So that's an important thing to keep in mind. The other thing also is if we look at the coronary circulation that supplies the right ventricle, The anterior part of the RV or the interventricular septum is going to be supplied by the LAD. The inferior part of the septum is supplied by the RCA, and then the RV free wall is generally supplied by acute marginal branches off of the right coronary artery. So here's an example just showing you kind of the bimodal perfusion of the interventricular septum, some coming from the LAD, some coming from the RCA and the PDA. And then the free wall, again, coming from the acute marginal branches. The other thing also is the effect or the response of the RV and the LV to afterload may be a little bit different as well. And so the RV tends to be a much more afterload sensitive chamber when it comes to stroke volume. So even small increases in afterload can lead to a significant reduction in RV stroke volume. And again, that's why the RV is much more sensitive than the LV is to any afterload changes. So let's talk a little bit about some of the pathophysiology of RV dysfunction. So, there's a variety of different things that can cause to RV dysfunction and RV failure. Complex congenital heart disease, pericardial disease, intrinsic myocardial processes, but also most commonly it's going to be either volume overload or pressure overload phenomenon on the right ventricle. And then in addition to that, you can have scenarios where there's ischemia and infarction in the right ventricle. So there's a variety of primary processes, but most commonly what you see as a cause of a problem to the right ventricle is in fact secondary to LV abnormalities or LV pathology. And here actually is just kind of showing the pressure overload phenomenon that can lead to RV failure. Most common obviously being left heart failure, which essentially causes a back pressure through the pulmonary circulation. But you could also have pulmonary embolism, which could lead to RV failure. Other causes of pulmonary hypertension, there can be cases where there's right ventricular outflow tract obstruction. There can be peripheral pulmonic stenosis, so basically not the pulmonary artery, but rather the main PA or the pulmonary artery branches, and then some congenital conditions as well. RV volume overload, most common is going to be due to tricuspid regurgitation, which again leads to excess volume flow over the right ventricle. You can also have pulmonic regurgitation, other congenital defects such as an atrial septal defect, anomalous pulmonary venous return, and then some other acquired conditions that are much less common. So I think the important thing to keep in mind is if you see an abnormality in the RV, you need to think about looking for the underlying causes that are leading to that. And so again, if you see an enlarged RV suggesting that there could be RV overload, look for underlying causes, whether that's valvular regurgitation or some kind of a shunt. And then this is just showing the relationship again between RV wall stress and RV ejection fraction, showing again that as the wall stress increases, the RV ejection fraction is going to progressively decrease. This is just a schematic showing kind of this relationship between the interventricular septum, the LV and the RV, that although they're separate component or they're separate chambers, there can be an interaction between those two. And as a result, if you have a dilated RV, it oftentimes will cause a compromise to the LV. So as a result, not only do you get this kind of flattening of the septum, you can get a smaller LV that can lead to reduced LV performance as well. I'm going to skip past this, and then let's go to talking about kind of what is the approach by which CMR is going to try to assess the right ventricle. So obviously, most assessments are going to start off with echocardiography, but if there's suboptimal image quality, that can be an indication to refer a patient for CMR. And then there can be scenarios where the RV can be hard to assess by echo because of a few reasons. One is image quality. The other important to keep in mind is that the RV has a very complex three-dimensional structure. And as a result, single 2D views may not give you a complete assessment of the RV. And so it's important to look at multiple different views to get an assessment of the right ventricle. Another important thing to keep in mind is when you think about the classic long axis 4-chamber view that you're going to obtain, well, where you draw that can have an effect on the size of your right ventricle. And this is just a schematic showing, in fact, that I've got 3 different views here, 1, 2, and 3, which all appear like 4-chamber views, but the size of the RV can be very different depending upon what angulation they're done at. And so one of the things is that on CMR, when you're prescribing the RV 4-chamber view, you want to make sure that you prescribe it such that it goes through the left ventricle, through the center of the LV, goes through the anterolateral wall and the infraseptal wall, but that it also goes through the maximum point of the RV. So you get the maximum exposure or the maximum size of the RV. And as a result of that, oftentimes you have to recalibrate your eyes if you're looking at CMR images, because the RV on a 4-chamber view will generally appear bigger than the LV, and will certainly appear bigger than what you're used to by seeing on echo. The other important thing is you want to use reference values for volumes, because again, it's a complex 3-dimensional structure, so any single 2D view may be misleading. So here's just some examples of cases of patients with an enlarged RV, as is shown in the left-hand side here. You've got somebody who's also got a thickened RV with RV hypertrophy, as is shown in this example image here. And here's what the appropriate use criteria talk about as far as when you would think about referring a patient on for CMR. And obviously RV is certainly one of the indications for referring patients for CMR assessment. So here's an example of a normal patient. You can see here the LV, the RV, and then the atrial sizes. Here's an example of a patient who has RV dysfunction. You can see, not just looking at the short axis, but also looking at the long axis view, you can see that there's a reduction in the free wall motion, and also look at the longitudinal motion as well. You can see that's reduced. And then this patient here who has a significantly dilated RV, so you've got RV dilatation. So, and then here is a significantly hypertrophied RV. This is a patient you can see with septal flattening, indicative of pressure overload. So what are the typical views that we're going to get? So in addition to the standard short and long axis views that we do for the left ventricle, there's a few additional views that you want to obtain to assess the right ventricle. So the most useful is this view right here, which we'll refer to as an RV 3-chamber or an RV inflow-outflow view. And the way that this view is prescribed, it's based off of the short axis and the 4-chamber views of the left ventricle, but you're trying to bisect through the tricuspid valve, or the tricuspid annulus. In addition to that, try to go close to the apex of the right ventricle. And this then gives you a view that shows you the SVC, the right atrium, the tricuspid valve, the right ventricle, the right ventricular outflow tract. You see the pulmonic valve here, and then the pulmonary artery trunk over here. And then a second view that you typically will want to get is basically a view that's orthogonal to this RV 3-chamber view. So this is prescribed off of the RV 3-chamber view, where you're trying to go through the right ventricular outflow tract, but at a 90-degree angle. And this now shows you a second view to look at the RVOT. So here you see the pulmonary artery trunk, the RVOT, and the pulmonary artery. Again, this view is not designed to look at the left ventricle, but it's designed specifically to look at the right ventricular outflow tract. And then when it comes to assessing size and function, we're going to do it similar to the way that we do it for the left ventricle, where when you have a series of short axis views, you can go through and planimeter each of the short axis RV views, summate the volumes together, and derive a volume for the right ventricle in diastole. And then you do the same thing in systole to arrive a value for the right ventricle in systole. If you look at from a reproducibility standpoint, the inter-study or inter-observe, this is the inter-study reproducibility. So if you scan a patient, take them off the table, put them back on again. For the RV ejection fraction, there's a little bit more variability. And again, this has to do with the fact that the RV shape is much more complex. So therefore, getting adequate contouring of the RV may be a little bit variable, but it tends to be about 6 to 10% for RV ejection fraction. Whereas for the LV, it tends to be on the order of about 3 to 6%. So again, a little bit more variability in assessment of RV volumes as well as RV ejection fraction. Where it's useful, obviously, is if you want to get an assessment of RV function, or as we'll touch on also, right-sided valve severity, but also can be useful in cases where you want to look for serial assessment over time. Now, one of the things, so I showed you how you can derive RV volumes. What you also want to know is what are normal. And so there's established normal reference ranges. These have been published now for over 15 years, and there's multiple different series that have looked at different cohorts of patients. A few important things to keep in mind when it comes to normal values is that they're different for men and women. So this is showing you for this European population that was published here in the European Heart Journal, the median as well as the standard deviation and the 95% confidence intervals for RV end diastolic volume, for indexed end diastolic volume where you divide by BSA. And if you look at the upper limits of normal, which is basically the upper limits of the 95% confidence interval, for men, it can be as high as 106 milliliters per meter square, whereas for women, the upper limits of normal was 92 milliliters per meter square. So again, differences clearly between men and women in the size of the right ventricle. Ejection fraction was not that different between men and women. So this is the lower limits of normal for RV ejection fraction in this series of 53 for men and 54 for women. So again, before you say you have a patient with an enlarged RV, make sure you index it to their body size and also index it to sex as well. The other thing is there's actually significant differences with age. So in this series here, they looked at patients across different deciles of age. So they had patients in their 20s all the way up to patients in their 70s. And if you look, again, and then this was stratified both by men as well as by women. And if you look at the upper limits of normal, which is, again, the right-hand side before the parenthesis here, you can see that for a 20-year-old person, upper limits of normal for a male may be as high as 114 milliliters per meter square, whereas for a male who's in their 70s, upper limits of normal is quite a bit lower, less than 100. And then obviously the same relationship occurs for women as well. So again, normal reference values change for the size of the RV, and as a result also you'll see the lower limits for the RV ejection fraction is a little bit lower for for younger patients than it is for older patients. So the common scenario you get is if you have a young person, their RV is going to be larger and the ejection fraction is going to be a little bit lower than what you would have for older patients. So when you do this, you want to make sure that you adjust it or you look at reference values for each decile of age. Yes, Steve?
Is that related to diastolic function? Diastolic function deteriorating with age?
Yeah, I mean, I think it can be that. There can be a few different reasons for it. I mean, I'm not sure all the reasons, but there's clearly differences. And we see this for the LV as well, right? That, and I think some of it has to do with probably compliance, that these younger ventricles are much more compliant and better able to fill. And as a result, then they don't need to eject as much, and as a result have a lower ejection fraction. Okay, so next, the other question that always comes up is, what's the ideal way to do RV planimetry? Do you do it off of short axis views, or do you do specialized RV views, either like a series of long axis or axial views to determine RV volumes and RV ejection fraction? And so this was a series that's about 10 years old now from a group out in Virginia, where they looked at patients and they scanned them both ways. They scanned them with a short axis stack like we normally do, as well as an axial stack specifically for the RV, and looked to say what is the RV stroke volume measurements that you derive, and then compare that to the flow coming out of the pulmonary artery based on phase contrast. And you can see here that the values are pretty closely correlated. Correlation coefficient of 0.84 with the axial approach versus 0.81 with the short axis approach. So the axial approach gave you a little bit better accuracy in measurements, again, using your PA flow as a marker as a reference standard compared to the short axis contours. But the reality is they're fairly close together. And remember, for almost all cases, you're going to want to assess the LV, so you're going to do that short axis stack anyway. So to do a whole extra series of images may not be practical. So most of the time, what we do is usually just do the short axis stack and use that both for the LV and the RV. There's some exceptions to that where you would want to specifically do a axial or long axis stack of the RV. And what are those example cases? What was that? Right, so those are the two cases. If you're looking for RV dysplasia, where you really, again, as I talked about, if you want to really look for regional RV function, you're going to better see that on long axis views and short axis views. So for RV dysplasia cases, it's important to do either an axial or a long axis stack of the RV. And then the other is congenital cases, and especially for patients who have Epstein's anomaly, right? Because that's where you're trying to figure out where is the tricuspid valve leaflet. Off of short axis views, it can be very hard to do that. So for 95% of cases, you don't need to do additional RV views, but there's some cases where you do. I talked already about the fact that the longitudinal shortening is a greater contributor for RV stroke volume than circumferential shortening. So let's actually now look at a case or two. So here, I've got a case. Let me break out of here and pull it up for you guys to see. Let's see if this will come over. Okay, here we go. Okay, let's look at this case here. So I'm going to give you no clinical history on this case. Somebody want to tell me what they see? So, and again, just for orientation, remember we've got the standard short axis views here. These are all typically every 1 centimeter apart. Then we've got the long axis views. This is a 3-chamber, a 4-chamber, a 2-chamber view. And in addition to that, since this is a specific RV study, we also did a stack of long axis RV views. So maybe you want to tell me what they see here? Okay, so the RV looks big, right? And you're saying that, why?
Well, in the short axis view, it seems bigger than the left.
Okay. Now, and remember what I said is you have to be careful about that statement, right? Because again, normally the RV is bigger than the LV, right? But again, this looks quite a bit bigger. Obviously, what I'll show you is the actual volumes that we derived where you went through and contoured it. But yes, the RV is definitely bigger. Okay, what else? Was that? Okay. Yeah, so the RV looks like it's dysfunctional as well, right? The RV ejection fraction does not look normal. And again, you know, I'll just tell you, this was a 56-year-old woman, okay? So, you know, we can look at the tables, but, you know, an RV ejection fraction for someone of this age group should be in the order of about low 50s at lowest, right? This looks lower than that. Okay, what else? Okay, so regional wall motion abnormality, and where do you see that? Okay, so you're looking at the stack of images that we have here. Does everybody see that? Look at the RV here. Look at the RV free wall. Is this wall actually squeezing in?
Based on what you told us, that most it's longitudinal. There's
right.
barely any longitudinal.
Right, exactly. You can see that if you look at the tricuspid annulus, the amount of motion isn't that much. There's really not much circumferential, right? There's not radial shortening. And also, it almost looks like this area right here looks like it bows out a little bit, right? Almost a little bit of an outpouching. So clearly, you've got some abnormalities here. Important, though, not just to look at these. There's a few additional views that we have. Let me see if we have these here. I'm going to show you a couple of more views. Okay, so if you look at, what about this view here? So remember, which view is this? This is that RV 3-chamber view, right? So this view, again, is good for looking at the infundibular area, right? What do you see here?
Aneurysm.
Yeah, it looks like an aneurysm, right? So what are you starting to think about?
ARVC.
Okay, so exactly. What you worry about here is there's regional RV abnormalities, there's an RV aneurysm, And it looks like you have a dilated RV with RV dysfunction. So to make the diagnosis, or to, for RV dysplasia, we have kind of specific quantitative criteria that you're going to want to use. And again, this is based on the 2010 task force criteria. So let me take you to that. And again, for this patient, let me just show you what the values were. So the RV volume for this 56-year-old woman was 200 mLs. Normal for this age, BSA, and sex should be around 150. So significant RV enlargement, and the RV ejection fraction here is 38%, so RV dysfunction. So if we look now at what the 2010 task force criteria for RV dysplasia says, and this is important, is you got to start with some abnormality of RV function. So you have to have regional RV akinesis, dyskinesis, dysynchronous contraction, or aneurysm, right? So in other words, it's not just an enlarged RV or dysfunctional RV, but it has to be some regional abnormality first, and then it's based on these quantitative criteria, either a RV end diastolic volume index of greater than 110 for men or greater than 100 for women. That's a major criteria for RV dysplasia, or RV ejection fraction less than 40%. That's a major criteria as well. Minor criteria would be just a little bit less dilatation or dysfunction, so essentially 100 to 110 for men, 90 to 100 for women, or EF between 40 and 45. Okay? Now, important, this just gives you one of the criteria. It doesn't make the diagnosis of RV dysplasia, because you need at least two major criteria to make a diagnosis. But this gives you the imaging criteria for RV dysplasia. Okay, so that's this case. Let's look at another case now. Here's another case. And again, I'm not going to give you any history to start with. Somebody want to tell me what they see here? And again, part of it, though, is be systematic about these cases and look at the LV first, look at the LV size, LV function, both global and regional, and then go to the RV. Anybody? Okay, the RV looks enlarged, but what about the LV? Okay, so basal infraseptum for the LV, you're saying, right? You're looking over here. You're looking over here. What about the inferior wall? Right, because look at this area, look at this area, right? It looks like it's kind of almost from about the 5 o'clock position to about the 7 o'clock position, right? Okay, so you've got some abnormality of LV function. And then what do you think about for the RV? You said the RV looks enlarged, right? Because the RV is significantly bigger than the LV, not just a little bit bigger. You can see it also on this 4-chamber view as well, right? Okay. And what else? Okay. So exactly. So it's not so much that it's global, right, as it is that the inferior diaphragmatic wall and a little bit of the free wall looks down more so than, let's say, the anterior wall of the RV. Okay? All right. And then I'm going to show you now our delayed enhancement MRI. Okay, so what are you looking for on these delayed enhancement MRI images? So, okay. So, right, LGE. So it's a little bit, LGE can occur in an acute setting where there's myocardial necrosis, acute injury or acute infarct, or it can occur in the chronic setting where there's chronic fibrosis and scar, or from non-ischemic scar. Okay, but you're looking for LGE on these images, so you're looking for high signal. What do you see? Maybe. Okay, so the kind of the infraseptum, right? And does this look like it's a non-ischemic pattern of injury or an ischemic pattern of injury? Ischemic, right? Subendocardial working out. It's almost transmural, right? And is there a coronary territory that this would fit? RCA. Okay. So that's the LV. Now look at the RV. So what you see here is you see hyperenhancement of the RV wall, right? Like look at the anterior wall of the RV. That looks nice and black. But look at the inferior wall, right? So, and again, this is where you can take a look here, right? See that? There's hyperenhancement here. See, it's brighter than the blood pool. It's not black like the rest of the myocardium in the RV or the LV is, right? So this actually is RV infarct as well. And if you go back and actually look at the cine images, it almost looks like the area that you're seeing of the abnormality correlates, the wall motion abnormality correlates with the area where you're seeing the hyperenhancement. Okay? So you can actually see RV infarct, not just infer its presence based on wall motion abnormality, but you can actually see it, right? Steve.
How does this present clinically? Right coronary infarct, so this is board stuff. They can present with predominant heart failure symptoms. They can present with epigastric discomfort instead of chest discomfort. And they also present with mechanical complications of infarct. Septal VSD, half muscle rupture. So that, beware the right dominant transmural infarct.
And that's getting to some of the slides I've got coming up. So, but this is, for this patient, these are just the specific volumetric numbers. So again, despite the fact he's got an inferior wall infarct, his EF is not that bad, right? But again, it was a regional abnormality in the inferior wall. His LV EF is 56, but notice the RV, dilated, significant dysfunction, okay? And then obviously, as we talked about, RV infarcts generally occur in the setting of RCA inferior wall MIs. Now, by definition, if there's an RV infarct, it tells you it's got to be the proximal or the mid RCA that's being affected, right? If the RV is also going to be affected as well. And then this can lead to hypotension, elevated neck veins, despite the fact that you have clear lung fields. RV infarct is associated with a worse prognosis. So if you have somebody who has RV involvement with an inferior wall MI, they're going to do worse. Okay, so let's go through next the tricuspid valve. So first of all, any questions so far on the RV? Yep.
Just a question about your approach to shared dysfunction of the septum. The scenario that we see quite often is bidirectional. One is they have massive RV hypertrophy, often with septal bowing, and then in the echo lab, the fellow or sometimes attending will say, normal LV diastolic function, which is impossible.
Yeah.
If the septum is bowed, the LV diastolic function cannot be normal. But the corollary is the blown out LV, probably from an LAD infarct, that involves the septum, and then the comment is RV size and function is normal, which it also can be.
Yeah.
Taking out the septum. So how do you allocate septal function, particularly when it's grossly different between the left and right side?
Yeah, so I mean, for our function assessment, it's less based on visual, and it's more based on actually what is the stroke volume divided by the end diastolic volume. So in that sense, in most of those cases, you will see that there is a reduction in the ejection fraction in those cases. But it's not based on a visual assessment, right? So
the septum's down and the free wall is hyperdynamic.
But so if the septum is not moving, right, then you're going to have inherently a reduction in the RV ejection fraction. Yep. Okay, so yeah.
It's often quoted clinically that after an infarct, RV function usually recovers with observation.
Yes.
Is there any data that if you see a RVLD, which I haven't seen that commonly, that
Yeah. Yeah, I looked. I didn't find any specific data, and I think because remember, keep in mind, in the setting of an infarct, wall motion abnormality can occur because of irreversible injury, i.e. infarct, or stunning, right? And I suspect that some of these cases what you have is maybe stunning of the RV without an actual infarct of the RV. But again, I haven't come across any studies that have looked at this systematically to say, okay, what happens to RV function if there's hyperenhancement versus if there's dysfunction without having hyperenhancement. Yep.
You always see that it,
Okay.
we see it often in echo and post-sternotomy. Post-bypass, you get RV stunning, which recovers in weeks and months without an infarct. It's very common to see in echo. They don't often get CMRs.
The other thing, I mean, to comment what you're talking about is it's important also sometimes, not fall into the trap of just looking for relative differences. Because oftentimes in these patients, especially with pulmonary hypertension, the RV dilatation occurs much later. So oftentimes they get a hypertrophied RV and they can get dysfunction. They don't generally dilate up right away. But because of the RV dysfunction, there's decreased LV filling, so the LV is small. So oftentimes you can have a RV that's dysfunctional with relatively normal size, but the LV that looks very small. And if you just look at the two visually, you'll say, oh, the RV must be dilated. So we come across cases like this where on visual assessment, it's thought that the RV is significantly enlarged. But in fact, if you look at it based on actual just volume criteria, it's not. It's just that the LV is very small because of an underfilled LV. Okay, so let's now turn to the tricuspid valve. And again, this is some of the criteria on how you approach tricuspid regurgitation from the 2017 AAC valve guidelines. And obviously, this is the echo approach, but it also kind of highlights the value of utilizing CMR in cases especially where you want quantitation of severity. Important to keep in mind that there's less experience, obviously, with the tricuspid valve and tricuspid regurgitant assessment than there is with the mitral valve. Now, what's the normal anatomy of the tricuspid valve? I think that's important to keep in mind. There's three leaflets. So there's the anterior leaflet, the inferior leaflet, and then the septal leaflet. So that's why it's called a tricuspid valve, right? Now, also important to keep in mind that the tricuspid annulus, just like the mitral annulus, is not just a flat planar structure. And in fact, it has high points as well as low points, and that's what's shown here. So in essence, if you look at it, in the four-chamber view, the part of the annulus that you're going to be visualizing is this area right here, which is actually the lower part of the annulus. And I'll come back to this in a second. But the important thing is when you're trying to assess the tricuspid valve, you can't really do it off of just one single view. You need to have multiple views. And part of the reason for that is if you have a single two-dimensional view, you can't be absolutely certain which leaflets of the tricuspid valve you're interrogating, unless you know specifically where your imaging planes were done. So again, for the four-chamber view, in general, the goal should be you should always have the septum, which is shown here. And as long as you have your four-chamber view such that it opens up the right ventricle, you should be interrogating the posterior leaflet. But again, if that four-chamber view is angulated a little bit higher, you may actually be looking at the anterior leaflet of the right ventricle. And then that's why there's these two additional views that we'll typically get. There's this view right here, which we talked about before, which is the RV three-chamber view, which should take you through the posterior leaflet of the right ventricle, and generally will be the anterior leaflet unless it's a little bit too septal, in which case it may touch the septal leaflet. And then for this additional view that we'll typically get, a two-chamber view of the RV, which is shown here, which will show you the anterior leaflet, and then it sometimes may, depending upon where it's angulated, could be the posterior leaflet or the septal leaflet of the tricuspid valve. One of the things we also know, and this is actually data, I mean, this is published in the literature 40, 50 years ago, if you look at pathology studies, is that there may be multiple subsegments to the tricuspid leaflet. So we talk about three leaflets, but there may, the actual anatomy can be somewhat variable, and there can be little kind of raphe within them, creating multiple subscallops. And this was a recent publication using 3D TE from Becky Hahn's group, which kind of just defined this in a more contemporary fashion compared to the original autopsy studies, showing in fact that although there's the three standard views, the septal, the anterior, and the posterior, it can look like more than just three leaflets. And again, it's just because of these raphe. So if you talk to surgeons, they're like, oh yeah, we see this all the time in the OR. But again, you need to be aware of this when you're looking at these leaflets. Okay, so next, so TR, what are the causes of tricuspid regurgitation? Well, in the US, what we're going to come across is primarily secondary TR. More than 90% of cases are secondary or functional TR. There can be some occasional cases of primary TR. So primary TR is caused by the etiologies on the left-hand side, so rheumatic, myxomatous, Epstein's anomaly, endocardial fibrosis, carcinoid disease, trauma, or iatrogenic, i.e., RV biopsies or devices crossing the tricuspid valve that could do some damage. Secondary TR most commonly is going to be due to left-sided heart disease, but it can also be due to primary pulmonary or precapillary pulmonary hypertension. And then there can also be some intrinsic RV cardiomyopathy, such as RV dysplasia that we talked about, that could then also lead to some TR as well, secondary. So here's an example. I don't know how well this shows up on the screen there, but if you look, this is a patient who has a signal void that we see in the right atrium, consistent with tricuspid regurgitation during systole. But if you look at the location of where that signal void originates, and let me see if I can slow this down for you guys. And I've got the nice little asterisk there to show you where the coaptation plane is. This is actually originating where that red arrow is through the leaflet itself. Right? So this would be a sign, an indicator that there may be perforation in this patient. And this person actually, in the OR, was found to have evidence of tricuspid perforation. This is just that same case here, just showing you other views, where you can see, again, the signal void that you see here is not originating from the coaptation plane, but is actually inferior to that, right? Because you can see the coaptation plane is right up here. This is actually coming through the leaflets itself. So again, an indirect measure or sign suggesting that this may be actually due to a perforation. Obviously, here's examples of patients with carcinoid heart disease, where you can see the tricuspid leaflets have very limited mobility. They're almost fixed and they're retracted, and you've got kind of a wide open jet of tricuspid regurgitation, as you see here. Here's a case of Epstein's anomaly. So you can see there's a huge elongated anterior leaflet. And again, if you look at where the tricuspid regurgitant jet originates, it's actually halfway down the right ventricle here, right? Because that's where the coaptation zone is. So this is a type of case, obviously based on short axis views, it can be very hard to try to get an assessment of RV or TR severity and RV function. Okay, so let's go on. So this is, again, is just talking about in the US, kind of where the distribution is of different causes of functional TR, which again, most commonly is due to left-sided valve disease, but it can also be due to pulmonary hypertension, LV dysfunction, and then some isolated or iatrogenic cases. So this is actually kind of showing the two different mechanisms of tricuspid regurgitation that's functional. One is that it's due to annular dilatation. This most commonly occurs in the setting of RA enlargement, so AFib, patients with chronic atrial fibrillation. And these patients will tend to have a basilar RV dilatation, whereas the other mechanism is due to papillary muscle displacement and RV geometry changes that lead to more of a leaflet tenting. So I'm going to show you two example cases of this. So here on the left-hand side, this is more of an atriogenic. You can see the leaflets, the way they coapt is almost a flat coaptation. If you can see it on this nice cartoon here. Huge atrium, almost a flat coaptation, and a dilated tricuspid annulus. On the right-hand side is an example here where you can see the RV here is dysfunctional, and you can see the tricuspid leaflets are actually tethered towards the RV. So as a result, there's a lack of coaptation. So different mechanisms. The left-hand side, again, is most commonly from atrial enlargement or atrial fibrillation. The right-hand side is what you'll see with pulmonary hypertension or with left-sided heart disease leading to secondary pulmonary hypertension. And then from the standpoint of assessing severity of tricuspid regurgitation, again, it's based on this concept of conservation of mass and conservation of flow. So we know that whatever's going through the right-sided chambers should be equal to whatever's going through the left-sided chambers, should be equal to what's going to the aorta and what's coming back from the systemic circulation. So if we look for any chamber which has excess flow, that's suggestive that there's a regurgitant lesion there. So for tricuspid regurgitation, the way that we would try to approach this is to determine what is the RV stroke volume, i.e. what's being ejected out by the right ventricle. And as long as there's not a ventricular septal defect, that flow then is either going to be going forward across the pulmonary artery or going backward across the tricuspid valve and representing TR. And so essentially using this equation of TR volume equals the RV stroke volume minus the pulmonary forward flow. We applied this actually to a series of patients from here with functional tricuspid regurgitation. And using this approach came up with different quantitative thresholds that are associated with worse outcome. And you can see one is whether you look at it based on tricuspid regurgitant volume or fraction, what you notice is that there's a progressive relationship. As there's more TR, more secondary TR, the prognosis for these patients is worse. But if we then stratify by different severity thresholds, the strata with TR volume of less than 30 was the lowest risk based on clinical outcomes. And then the strata with a TR volume of more than 45 or more than 50% represented the highest risk group when you look at prognosis. And this is just showing that data in Kaplan-Meier curves. And again, this was actually even after you adjusted for PA pressures, MR severity, and RV ejection fraction assessment. This is some data from European or from Korean group, which looked at patients that went for surgery for severe tricuspid regurgitation, and looked to say what baseline RV ejection fraction stratified risk in these patients in the postoperative period. And they found that an RV ejection fraction of around 46%. If it was less than that, those patients did worse. They had a worse long-term survival versus those that had an RV ejection fraction preoperative of more than 46%. And then this is some data from here showing also just looking at patients not just that are going for surgery, but just longitudinally, all patients with moderate or severe functional TR, that an RV ejection fraction of 47% identified a higher risk group of patients. So this is what the guidelines say about when you would think about utilizing imaging in tricuspid regurgitation. And again, I'm not going to bore you with the details, but I think it really says when there's a question of assessing the RV severity, either RV function, RV volumes, or if there's a question of TR severity assessment where you don't have a good assessment by echo, those are all scenarios where you could think about getting a patient referred for CMR if you're considering especially doing some interventions on this patient. Yep.
Question. Practically speaking, is your way, I mean, there's a lot of parameters that you use to assess the TR, but when we diurise the patient quite a bit and we change the organ status, how much you see difference in terms of regurgitant fraction? That's going to be the thing that I look at mostly. I'm not sure how much.
Yeah, no, I think that's a very good question, which is TR, just like, like secondary MR is dynamic, TR is very dynamic as well. It's very load dependent. So if you diurese a patient, you can get a significant reduction in TR as well, especially when it's secondary TR. So the goal with most of these studies is they're looking for patients who have, despite optimization, persistent significant TR, right? And that's kind of what gets to this whole issue, even for the mitral valve, right? Again, is you don't want to target interventions until you've optimized the patient medically, right? Yeah.
So the guideline recommendation on the prior slide you had to do a tricuspid ring if the annular dimension is greater than 40, the second one there.
Yeah.
Historically, that's based on the surgical evaluation of open chest.
Yes.
Which is kind of a septal posterior measure. So does that correlate well with an MRI measurement, and if so, what view?
Yeah, so that's a good question because let me get to some other slides that I've got, because I think the question I think that's being brought up is the surgical literature suggests if you're already in there and you've got a dilated annulus, even if it's moderate TR, you should go ahead and put a ring in. Most of this data, though, if you think about it, is based on people with mitral valve disease. That's what, almost all of these cases where these surgical criteria come from are patients that are getting their mitral valve operated on, that while they're in there, they say, okay, if we don't fix the tricuspid valve, if the annulus was more than 4 centimeters, then they have a worse prognosis. So I'm going to show you something, and this is a little bit more thought-provoking than anything else, okay? Which again, I think it speaks to the fact that when it comes to the right ventricle, and especially for TR, I think there's a lot we still don't know. Which is, look at this case here. And what do you guys think about this case? What do you, yes, what is it? Yeah, the tricuspid valve is prolapsing, right? So is this secondary TR?
The mitral, the left ventricle looks okay.
Already dilated, so maybe
Looks like
there's
primarily RV pathology.
Right. So I think it's getting to this issue of is the prolapse due to left-sided valve disease, or is this a primary abnormality of this valve?
It's like primary, sir.
Yeah, I mean, because if you look at that first slide I showed you guys, right, that talked about primary tricuspid regurgitation causes and secondary tricuspid regurgitation causes. Prolapse of the tricuspid would be a primary cause, right? There's a primary leaflet abnormality, right? So the question is this what you see in the setting of mitral valve prolapse, right? Because there's been, if you go back 30, 40 years, this was a New England Journal paper, 1972. Okay, New England Journal, 13 patients with prolapsed mitral leaflet, and they just talked about the fact that some of these patients, half of them had tricuspid leaflet prolapse. Okay, so again, the beauty of it, if you were 50 years ago, 13 patients you can publish in the New England Journal. You're not going to get that today. But the whole idea is a lot of these cases that we think is secondary TR, that we think about the surgeons we're operating on, which again, most of that data is all based on operating on mitral valve disease, which is mainly degenerative MR, right? Mitral valve prolapse cases. Is that applicable today? So I'm going to kind of walk you through, this is some recent data that we just published last year, which is to say, how do you define tricuspid valve prolapse, right? Because there's not really any kind of set criteria. Do you just say, use the same criteria that we use for the mitral? So this is one of the fellows last year worked on this project. We went through first, looked at a series of normal cases to say what is the normal, because we know the tricuspid annulus, again, is not planar. So what's a normal displacement of the tricuspid leaflets that occurs depending upon which view you're imaging from, right? Because we learned from the mitral valve, again, if you look at the 4-chamber view, everybody will have prolapse because there'll be some displacement of the leaflets, right? So you need to know what's normal to then define what's abnormal. And using this, we actually kind of came up with a set of criteria, which is that for the anterior and posterior leaflets, more than 2 millimeters represents what was outside of normal patients, or normal volunteers. But for the septal leaflet, you need up to 3 millimeters, right? And again, that's because the septal point of the tricuspid annulus is not the high point, it's the lower point, okay? So if you use those criteria and say, let's look at what is the prevalence of tricuspid valve prolapse amongst patients who have mitral valve prolapse, right? One is, in healthy volunteers, nobody had prolapse. In a kind of a control group of non-MVP patients, so patients without mitral valve prolapse, who had MR, none of them had tricuspid prolapse. So it's only in those patients who had mitral prolapse. And it was much more common in those with bileaflet mitral valve prolapse. So again, the question becomes, obviously, if you have an underlying primary mitral tricuspid valve abnormality, if you're at the time of the OR, you don't fix it, it's likely to progress on. So could that be explaining some of the discordant findings that you see in the surgical literature? And in fact, what this showed was that those patients who had tricuspid valve prolapse, they're the ones who had a higher proportion of moderate or severe TR. Okay, so again, this is more thought-provoking, but I think getting back to the question of where do that 4 millimeter though number is actually based on imaging data, right, of 4 millimeters. The surgeons will tell you that the size that they get is even bigger in the OR, right? But the criteria when they went back and said, okay, let's look at echo studies, say what severity or what annulus size correlated with the worst outcome, it was when by echo there was more than 4 millimeters for the tricuspid annulus size. So I think getting to, especially in the transcatheter era where you can do these staged, I think maybe you can separate these out. And you can see, okay, does it progress on or not if I fix the tricuspid or if I fix the mitral without doing anything to the tricuspid. But I suspect that some of this may in fact be due to the fact that a lot of these patients may in fact have had a primary underlying tricuspid valve abnormality that's a primary process, not a secondary process. Okay, so let me wrap up here because we're right at 1:02. So you can use CMR for assessment of the RV when you want to look for regional abnormalities, when you want to look for RV chamber sizes and dimensions. Most tricuspid regurgitation we know is going to be secondary to left-sided valve disease or pulmonary hypertension. And then also this new entity that we've recently identified of kind of tricuspid or atriogenic tricuspid regurgitation just like we have for the mitral valve. And then there's now CMR-based quantitative thresholds for TR severity that portend worse risk. One of the things I didn't touch on, because again, there's limited CMR data on this, is being able to assess PA pressures. So I think that's still an emerging role for CMR. And I think that's an area where echo really does stand out, or invasive hemodynamics. So with that, I thank you for your attention. Okay, any questions, comments?
Awesome.
All right, thank you guys.